Thanks very much for inviting me. It's certainly a pleasure to talk to you. This is an exciting time for you. We were in the same position in 2006. Our group had the same angst as you do. This is really a change of how we do things in the intensive care unit with respect to solid organ donation. Up to this point in time, we spent a lot of time developing guidelines for how we manage potential donors, NDD donors, in our intensive care units. And the idea was to maintain adequate perfusion of warm, oxygenated blood, and that would facilitate good organ function post-transplant. Now, we're allowing patients to die following confirmation of cardiac death. We take these organs and we transplant them. They all have ischemic injury dependent upon how and how long it takes them to die. So this is a really considerable change of how we think about things, and so that was the angst that we dealt with early on. So what they've asked me to do today, I'm not going to be scientific at all. I'm going to give you my perspective on how we dealt with the implementation of a DCD policy. I had an advantage. I come from a medical surgical ICU that supports a transplantation program. In other words, everyone I work with, the healthcare team, including the operating room, including the administration, was pro-donation. And everyone was fully aware the benefits of donation. So that was a tremendous advantage that I had. What I'd like to do this morning is present a case that happened to us, what we learned from this case, and how it changed our policy and how we actually do things. I'll talk a little bit about standard policies and practices, some of the challenges that I thought were more important and what we went through during the implementation, and hopefully we'll end up with a success story. Okay, we all learn from experiences, and as you experience cases of DCD, this will change how you do your DCD, what worked, what didn't work, and you're going to revise your policies as you go through this. And as you have more DCD cases, you will become much more comfortable with those cases. You will also begin to appreciate the benefits of doing donation after cardiac death, including you're giving organs to save people's lives. But one thing we can never underestimate, or overestimate, I should say, is the benefit that this has for families to donate. This is extremely important. And it's amazing how thankful these patients' families are once they go through this horrible process of losing a loved one. The fact that they're able to donate organs is extremely important. I can't overemphasize that. This is an 18-year-old male, severe head injury, and multiple facial fractures, soft tissue injury as well to the neck. And the likelihood of this individual even surviving this injury was pretty small. We aggressively auto-resuscitated him, neuroresuscitated him, and despite that, he went on to develop refractory cerebral edema. The neurosurgeon discussed this case with the family, and there's no way this patient was going to survive without performing a craniotomy and perhaps a lobectomy to allow this brain to swell. Family says he's 18, let's do whatever we can, let's have him given the best chance of possible surviving this devastating injury. Well, a craniotomy was performed, a lobectomy was performed, and the neurosurgeon was really impressed at the extent of the injury to the brain tissue at the time of the operation. Immediately following the operation, on the OR table, minimal anesthetic agents on board, the neurosurgeon performed a cursory examination. Pupils were fixed and they did not respond to stimulation, and there was no stimulation response to deep suctioning or peripheral pain. He subsequently talked to the family and told them the extent of this patient's injuries, what they did, and that this patient was brain dead. Patient was then subsequently taken to the intensive care unit, and of course, when he arrived in the intensive care unit, we recognized there were a number of electrolyte imbalances, and we couldn't even measure this patient's core temperature. Any of our instruments that we used did not measure his temperature. So we explained this to family and said, look, before we confirm evidence of brain death, criteria of brain death, we need to warm this patient up, correct the electrolyte disturbances, which we did. And sure enough, over the next 3 or 4 hours, this patient's pupils began to react. Sluggishly, but to react. We discussed this with family. We could not confirm brain death under these circumstances. We'll continue to medically manage this patient as best our ability, and let's see what nature takes its course. And as expected, patient's pupils failed to react over the next 3 to 4 hours. There is no stimulation to deep suctioning. There is no breathing above the ventilator, and we assume this patient was brain dead. The problem is we could not confirm all neurological criteria, so we discussed with family, we need to proceed with ancillary testing. We talked to the neuroradiologist, and because of the extent of the injuries, recent surgeries, soft tissues of the neck, he suggested that we perform the gold standard 4-vessel angiography, which we did. And we received a phone call from the resident following this procedure to the bedside nurse saying there's no flow. Again, not expected. Unexpected. We went to the family and said, we have confirmation of cessation of brain blood flow. The patient is legally dead, neurological criteria. Let's pursue organ donation, which they wanted, and that process was underway. 1.5 hours later, we get a call from the neuroradiology consultant who was reviewing the films, and he said, we have a trickle of flow. We cannot confirm brain death. Who wants to go to the family with me? Anyway, we went to the family, and we said, look, this is the circumstances here. We cannot confirm brain death with ancillary testing, and the recommendation is we wait till tomorrow and repeat the testing, and it's more than likely that we will have confirmation tomorrow morning. The family was emotionally exhausted. They said, we can't go on any further. We have to stop this. We know our son would like to donate organs, but we just can't bear this. So we offered DCD. And through a number of phone calls, talking to everyone involved, the surgeons, the OR, the ICU staff, we were able to proceed with DCD donation at the same time frame that was booked in the OR for the NDD with removal of organs. And fortunately, we were successful, and this patient died very quickly, as one would anticipate. There was no breathing from this patient, and we were successful in transplanting liver and 2 kidneys. We had a post-debriefing of this case with everyone involved, including the radiologists, including the neurosurgeons, and we made some important decisions with respect to how we proceed in the future with respect to declaration of brain death and what we do with ancillary testing. For instance, unless we have a written report with respect to ancillary testing from the consultant, we will not accept any other confirmation of this test. Failing that during the evenings or on weekends, it's a direct communication between the consultant and the ICU consultant to confirm ancillary testing, for instance, okay? I think the point here is we have developed neurological criteria, we have developed cardiac criteria. We need to adhere to those criteria and not deviate from them, okay? That's extremely important. Fortunately, this family was intelligent, and they were thankful that we were rigid in terms of adhering to these criteria. Even though their son was declared dead 3 times, they understood the process and they appreciated that. And they're exceptionally appreciative of the fact that we ended up able to donate solid organs. Okay, so Sam talked about the development of the Canadian criteria for donation after cardiac death. These criteria, these guidelines, recommendations need to be embedded into your hospital policies, and you need to adhere to them. And this gives us a framework to develop your hospital policies. That's extremely important. What is the role of the intensivist? I think first and foremost, you are very fortunate in that you have a leader, a champion, Albert, or Adrian, excuse me, that he's extremely interested, and he's a leader, and he's going to push this forward. And that's what you need. Without that, you're going to fail miserably. It's important to develop educational programs for everyone. That not only includes the healthcare intensive care unit team, but includes everybody in your institution, including the individuals in the operating rooms, and including administration. There are 3 roles that we obviously take with respect to donor recognition as intensivists in the intensive care unit. First and foremost, you need to identify all potential donors in your intensive care unit. And we'll talk about that as to how we can do that efficiently in a few moments. So the first thing is identify a potential donor. And the second thing is you give the information to families, the pertinent information that they require to make an informed consent, okay? And it's their right, it's families' and patients' right to give them an opportunity to decide. And once they've made that decision with the information you give them, you need to respect that decision without coercion. Okay, so identify donors, give them the information that they need to make the decision, and once that decision is made, you accept that. Okay, there are key questions, and I think these 3 questions really are parts of many of the discussions that you will have in your development of your hospital policy. Who's affected by this policy? Where are you going to withdraw your support, your withdrawal of life support? Is it going to be in your intensive care unit where we do it at our site because or at Victoria Hospital site because the ORs are adjacent to the intensive care unit? Or are you going to withdraw in the operating room, in the recovery room, where we do it at our site because we're such geographically located away from the operating room? Every second counts. Once this patient has been declared cardiac dead, this patient is immediately transferred to the operating room for removal of organs. These organs are dying, they're undergoing ischemic injury, every second counts. Secondly, what barriers might affect their acceptance? OR time is extremely important here, particularly at the Victoria site in London. It's a trauma center, lots of orthopedics, they're going 24/7. You need support, financial support, to support these programs. You need to define and create business models in order to make sure that these programs do achieve what they need to. You consult and you engage key stakeholders. That's everybody. My first meeting was with my ICU group, only my ICU group. And they all had angst about this. They knew I was going out west to look at this, develop these forum for developing the Canadian guidelines. Everybody had some angst. And the angst was, why are we going to do this? These organs are going to be bad. They're not going to work. Well, the point is, you need to look at the evidence. You need to look at the experience. And yes, there are time restrictions of the withdrawal process and what organs are viable after certain time frames, but this is extremely important. Guess what? It does work. So I think first and foremost was the ability to convince my colleagues that this is something that we should be doing and doing it well. We continue to have some angst with some of our colleagues. They supported the concept, but they did not want to be involved in the actual DCD process. Fair enough. I know all of you will have some angst. I know all of you will have some questions. Don't sit there silently. Voice your angst, voice your questions. In each and every one of your questions, and angst is important. I don't care what are you or who you are, it's important to express your angst at some form so that everybody understands what your perceptions are and what your problems are. Not problems, but angst about the decision about doing DCD. And you know what? Not everybody agrees with it. Not everybody agrees with it in our institution. That's fine. You need to appreciate that, and you need to expect those decisions and attitudes. So, discomfort of team members, we've talked about that. Most important thing is communication. Misperceptions of DCD. People thought we actually took patients to the operating room during the withdrawal process before the heart died, removed organs. That isn't the case. So I think it's important to discuss the actual process. We spend a lot of time with families to talk about the process, and we'll talk about that in a minute. There are competing interests in the OR. How are we going to make this happen? At the Victoria site, we have on-call nurses who have volunteered to be on call so that in case there's A cases going on in the OR, which is frequently, this will not delay the DCD process. Or if a DCD OR time has been set and an A case comes through the doors, then we can call this second team to come in and proceed without delay. Prolonged waiting times for families. The amount of time families wait to the point of withdrawal is almost twice as long as if you're dealing with neurological criteria. And there's a reason for this. We want to ensure that in most cases, proposed DCD donation, which are head injuries and or hypoxic injuries post-cardiac arrest, we want to ensure that these patients, despite our resuscitation, will not proceed to accept neurological criteria, okay? And the point I always make with families is there's no guarantee with DCD that they're going to die, and that if they do die, they will die in the prescribed time frame. For instance, at 30 minutes, once we begin the withdrawal process, if the patient has not fulfilled cardiac death within 30 minutes, we cannot use the liver anymore. Pancreas, 1 hour, lungs are 1 hour, kidneys are 2 hours, some centers that has been extended. So there is a time frame that we must adhere to strictly, because each and every one of those organs is undergoing ischemic injury, and we want to ensure that we're transplanting viable organs. So we always talk to families and say, there's no guarantee here. What we would like to do is to see if the patient does proceed to fulfill criteria, neurological criteria, and that will allow us to, permit us to have the opportunity to have organ donation much more than cardiac death criteria. IV heparin. There's no benefit to the patient to give someone IV heparin. We've already heard whether this proposal is actually does any good at all. We do administer IV intravenous heparin during the DCD process. What you do not want to do in any withdrawal process is hasten death. So if patients are in the consideration of administration of heparin, may cause them to have a hemorrhage, such as patients with GI bleeds or patients with intracerebral hemorrhages and so on. If there is a possibility that administration of high-dose heparin may cause bleeding, then don't give it. We will talk to the surgeons about that. They will make the decision whether or not we proceed or not. So that's extremely important. I may point out that part of the consent process is we definitely talk to families about administration of heparin to their loved one, despite the fact there's no benefit. The benefit, we presume, is the viability and of the organs during the withdrawal process. Okay, withdrawal process. I want to spend a little time on this. This is important. The way you withdraw life support from your patient should not be any different as if whether you're a donor or whether you're no donor. Most of the withdrawals that occur in our intensive care unit, the donation is not on the table. But whether it is a donor or not should not affect how you withdraw life support, okay? One of the greatest fears in my experience that I have with respect to withdrawal of life support is not giving too much drugs as if you're hastening death. But in my experience, I often see, particularly nurses who are recent grads, they're not giving enough medication, and patients actually are suffering during the withdrawal process. That's the number one concern that I have. What I've done is I've changed my approach to withdrawal of life support, and it had nothing to do with DCD. What it had to do was some of the angst that some of the nurses had with respect to, my God, you're ordering all these medications. You know what? You've all seen it. Patients die with quite variable needs of medication. Some patients require little, some patients require a heck of a lot. And if you look at the nursing record following the withdrawal process, it can occur in a short period of time. And if you look at the amount of medications given, someone's going to say, my God, you've killed that patient. You've euthanized that patient. So that angst did come across very clearly from some of our nurses in the intensive care unit. So what we've done is we've implemented in terms of the order sheet, and we give them, you administer medications if there's signs or symptoms of discomfort. That's pretty easy. And we've also given them physiological criteria. So if someone's tachycardic, they're hypertensive, they have a high respiratory rate, give them medication. And I tell the nurses, once you give that medication, or 2 milligrams of Ativan, or 2.5 milligrams of IV morphine, put in brackets why you've given that medication. I can tell you the relief of angst with respect to how much drugs given to these patients has now been resolved. And that's extremely important. So we titrate medications to ensure patient comfort and to ensure patients die with dignity and not discomfort. We do not euthanize our patients. We give them death with comfort and dignity. Okay, lastly, unpredictability of death. We've alluded to this. This is Ontario data starting at the bottom from 2006 to 2007 fiscal year right up to the end of 2012. The green bars are the actual DCD donors. The blue bars are those ones that did not die in the prescribed time frame. And the percentages that you see here is the proportion of patients who failed to die, okay? And you can see in 2009, 2010, that represented 35% of the attempts. That's a lot of resources wasted. We get nothing out of it. There's a lot of people involved here. It's occupying the OR for up to 2 hours, and yet only 35% of these patients actually went on to donate. Or 35% of the patients' attempts did not follow through with donation. That's too high. We've talked about, are there any other tools, developing better tools to predict whether patients do die? We're still lousy at determining whether patients will die. We think they're going to die, but we don't know. So I think what we've done since then, I think we've selected our patients a little better. And again, I think it's important, and we're continuing to do that and currently developing tools that may help us better prescribe whether or not these patients actually will die. But this is a given. It's not going to get to zero, I can guarantee you that. But this is important information that you must give to families in terms of there's no guarantee. This is a timeline of DCD, actually how it works. We can start at the far left. We have a hopeless situation. Despite our aggressive management, the outcome of this patient is poor. We all have our discussions with patients, families, and SDEMs with respect to what's our next step. How do we change our management? We come to the conclusion that we need to withdraw life support. Donation has not come into this picture at all during this process. Sometimes it does come across prematurely, and that is coming from families. But the decision to withdraw a life support system is the trigger for DCD. NDD, in most situations, it's obvious. But in DCD, this discussion does not occur until the decision has been made to withdraw life support. We'll talk in a minute a little bit about who makes those decisions. And once that decision is made, we spend an inordinate amount of time talking to families in terms of how this process works. This is extremely important. In all of our DCDs in London, all but 2, families are at the bedside. And this is in the recovery room. They don't have to put on greens. They have their street clothes on. They come to the recovery room. We've cordoned it off. It's very private. We've had 15 people around the bedside during the withdrawal process. What's important here is we talk to them how we withdraw support. In other words, medications and how we administer those medications. We don't give something that stops the heart. We give those medications to ensure comfort and dignity. We take out the breathing tube. When we take out that breathing tube, they may cough, they may sputter, they may turn blue. This is how people die in their sleep, okay? We can assure patient's family that their comfort, even though they may look bad, they're going to be comfortable, okay? This dying process is extremely important because there has to be no surprises to the family during this process. And we haven't had one yet. But these families know more about DCD than most people that work in our ICU because we've talked to them and they experience it, okay? It's extremely important. And so once that has happened, we tell families, look, time is of the essence here, all right? We are on a clock. And once we reach certain time limits, the ability to donate a liver is gone, the ability to donate a lung is gone, a pancreas is gone, and at the end of it all, at 2 hours, the ability to donate kidneys is now gone. It's really eerie. The families are sitting there. You know what they're looking at? Their watches. They're looking at the clock and they're counting. And you reach a point during the withdrawal process where the patient is very comfortable. The heart rate's low, the blood pressure's low. You may not have a saturation. There's no signs of discomfort. You don't administer any more medications. And yet the families are looking at you, looking at the watches saying, doing something. Make them die. So it's an eerie feeling. But stick to your guns. Stick to your protocols with respect to the withdrawal process. Okay, who decides? This is extremely important because we are privileged and we work in a tertiary care unit. The subspecialist is usually the most responsible physician. This could be a neurosurgeon usually. It could be a neurologist. It could be a cardiologist. We have the intensivist because we have a two-team approach on a daily basis, a day team and a night team. We have 2 intensivists making rounds. So there's at least 4 opinions that come together to determine whether or not we should withdraw life support. At least 4, okay? I think one person making that decision is difficult. I would recommend, highly recommend, a second opinion. But at least 4 opinions determine. And if there is anyone on the team, physicians, nurses, whoever, RTs, that are concerned about the decision to withdraw life support, you stop. You don't go any further. You sit down and discuss the angst. That's extremely important. It shows you that you're supporting the team and there's something that they misunderstand or don't understand as to why we've come to that conclusion. So I can't emphasize that even more. Here's the success story. We started in 2006, and you can see that the blue bars is our NDD activity, and we are seeing a decrease in NDD activity. We've had 2 spurts in 2011 and 2013, but we're seeing a decrease in trends, and we're seeing that in other transplant jurisdictions as well. We're just not seeing them. I mean, there's lots of reasons for that. We have much safer cars now. The Chevrolet Cruze has 23 airbags in it or something like that. If you ride a bike in London without a helmet, the cops will stop you and take their bike and put it in their trunk. Seat belts. We manage patients better now in the ICU with neurological injuries, hypertonic saline for trauma, hypothermia protocols for post-cardiac arrest. More people are surviving. We're seeing less patients who fulfill neurological criteria, okay? That's a given. And yet the people who need organs, they're not going away. Our patient is growing. Our patient population is growing. They're also becoming older, and the needs are there. What you see in the red is the response activity of DCD. And this has been tremendous, and it's a growing activity within our hospital. And you can see that 39% of our total organ donation was DCD. Originally, when we started this program, way back when, we predicted that perhaps between 10 and 30% of patients in your intensive care unit could be potential DCD donors. We've now reached 39%, and the UK data is up to 50%. So this is certainly a potential to increase your donor pool, right? And these are patients who normally, prior to DCD guidelines, These were patients who would never become donors. So again, the families are so thankful that this is an opportunity for them to have a decision to go forward. How much time do I have, Adrian? 5 minutes. Perfect. 2011, I was involved in a case, 68-year-old woman, collapsed on a treadmill, on no medications, healthy as a horse. She had a huge cerebral hemorrhage from an anterior communicating artery aneurysm. 68. Neurosurgeon, dismal, lousy prognosis. Family, we don't want her to be left on life support. We want to withdraw life support. Everybody concurred. We withdrew life support. The next day, I get a call from my Trillium organ coordinator, and she said, why did you withdraw life support? I said, she was 68. She did not fulfill neurological criteria. She wasn't a potential for DCD. She said, why did you withdraw? And I said, she was 68. Well, Toronto, who does all the lung transplants now, transplanted 2 single lungs in a patient, age 70 donor. Patient went home 2 weeks later. The age cutoff now for lungs in Toronto for donors is 80. It's amazing. So we have a moving target. We have a moving target for neurological criteria organs. We have a moving target for DCD organs. We have extended criteria. These are going back and forth, up and down. The point is, I can't know this anymore. I used to, but it's just a moving target. So the important thing is we need to understand how we can pick up every potential donor in your intensive care unit. So this is what we developed. It's a one-page algorithm. And all it is once you've made the decision to withdraw life support, that's your trigger for this algorithm. And it tells you, stop. You cannot initiate withdrawal process until you reach the bottom. What it tells you to do is call the provincial procurement agency in Ontario, that's Trillium, and they say, is this patient a potential donor? We give them the specifics of the patient, and they say yay or nay. If it's yay, the next question is this patient on the affirmative registry in Ontario? Because that's important information that we can take to the families. It's interesting. People used to sign their license, their health cards. Now we have an affirmative registry, but they never tell anybody they've done this. So this is useful information that you can take to the family and say, oh, by the way, did you know he's on the registry? We did not know that. So that's helpful in supporting their decisions to go forward with donation. So that's it. It's simple, one page. Stop until you get to the bottom. You won't miss any donors at all, if you apply this appropriately. This is just briefly how this helped. Referrals to TGLN, Trillium, went from 104 to 134, which is expected. We didn't change the number of donors we had. You don't invent donors with this process. What you're doing is prevent missing donors, okay? Before implementation, we missed 8 donors. Following post-implementation, we missed 2. And that was because we didn't educate everybody, all right? But the whole point here is you decrease the number of donors that you do miss in your intensive care unit. This is part of your end-of-life protocol, right? Okay, sustainability, in summary, realize your experiences and opportunities and tell people your experiences. Tell them the successes that you have with DCD. I meet with the OR nurses at both sites once a year. Their perception is they have a dead person coming in the OR and we're taking organs from them. How can you take organs from a dead person? They're not going to work. So what we do is we go and say, this is our activity last year. Here's how many organs we transplanted successfully. That is huge. And it changes perceptions with respect to DC dramatically. Continue to educate. Continue to educate. It's a turnstile of people working in intensive care units. Residents, fellows, nurses, docs, continue to educate. It should be part of your educational program within your intensive care unit. Be cognizant of patients, people's, healthcare team individuals, beliefs and attitudes, and respect them. You're not going to convince everybody that this is the thing to do, and don't expect to do that, but respect their differences. Thank you very much.